Good afternoon. We ran this webinar last summer. After the lockdown, it was noticed that Shigella cases were increasing again in England, and those trends have continued. If we move on to the next slide, thanks. This month, we launched a relaunch of the campaign that we had last year, Maybe It's Shigella, with digital advertising targeting gay and bisexual men in England on a number of different channels, so through social media, Facebook, Twitter and Instagram, and geosocial apps as well. The awareness campaign is directing people to the Sexwise page. If you don't know about Sexwise, it's an online resource that talks about all different STIs. And the information on there is providing people with an update on kind of the current context with Shigella, what to look out for and what to ask for if you think that you have it and you're contacting a health professional. There's also support for the sector, and you can take a look at our website, HIV Prevention England.org.uk, to access these. So UKHSA and BEVA published some resources for health professionals earlier on this year. And then we have our campaign resources, so leaflet posters, which are available as PDF, as well as ordering physical assets, as well as the campaign creatives and assets and messaging for your social media channels in your local area. That's an update on the work that we're doing. I'm going to hand over now to Hannah Charles, who's a senior scientist concentrating on HIV and STIs. Thanks, Hannah.
Thanks, Alex. I'll just share my screen. Is that showing okay?
Yeah, that's great, thanks.
Wonderful. So hi, everyone. Thank you for joining this Shigella webinar this afternoon. So as Alex said, I'm Hannah Charles, and I'm an epidemiologist within the STI team at the UK Health Security Agency. So I'm going to be giving a brief introduction to Shigella and providing an update on the epidemiology of sexually transmitted Shigella in England. I'll also provide an update on a recent outbreak of extensively drug-resistant Shigella sonnei. So as a bit of background, Shigella is a bacterial enteric pathogen that causes dysentery, where symptoms include diarrhea, stomach cramps, and bloody stools. So these can range from mild to really quite severe. And symptoms start between 12 to 96 hours after exposure and typically last between 4 and 7 days. So there are 4 species of Shigella, and I'll focus on Shigella flexneri and Shigella sonnei, as these are the species more commonly associated with sexual transmission in the UK. So it's also worth noting that Shigella flexneri is a notifiable disease, and cases should be reported to the local health protection team. So Shigella is transmitted through fecal oral contact. So this can be during travel to endemic countries where somebody becomes in contact with contaminated food or water. But this route of transmission is rare in the UK. However, sexual transmission of Shigella among men who have sex with men is increasing, particularly in London and Manchester. So for example, in 2019, more than half of all cases of shigellosis among adults in England were attributed to sexual transmission among MSM. Shigella is also highly infectious and easily spread. So this figure shows Shigella diagnoses by gender and travel history, and the data is presented quarterly. So we're starting at 2011 and going all the way up to 2021. So the dark blue dashed line shows cases among non-traveller adult males, which we use as a proxy for MSM. So between 2 and 4 times more diagnoses are made in this group compared to the other categories. So following a peak in diagnoses in 2019, infections fell sharply in 2020. And this decline was greater for travel-associated infections, which coincided with COVID-19 restrictions. Cases associated with international travel remained low throughout 2020 and 2021. So the data suggests that transmission continued among MSM during the pandemic, albeit at reduced levels. But we have seen a substantial increase in cases among MSM since September 2021, and we'll come on to that a little bit more later. So as I mentioned earlier, there are two species of Shigella that are more commonly associated with sexual transmission. So we've got Shigella flexneri in the dashed line and Shigella sonnei in the solid line. And here we're looking at cases among MSM. So while the impact of COVID-19 restrictions had a greater impact on reported diagnoses of Shigella sonnei, the substantial increase that we've seen among MSM since September 2021 has mainly been driven by this species. And this was declared a national outbreak a little bit later in the year. So we only know about symptomatic reported diagnoses, so it's very likely that our surveillance data underestimates the true situation of sexually transmitted shigellosis. But of the cases that are reported, nearly 60% are reported in London. Outside of London, the northwest and the southeast are focal areas for Shigella. So the next few slides, I'll describe the national outbreak of extensively drug-resistant Shigella sonnei. So as I've said, in September 2021, we saw the start of a substantial increase in one particular cluster of Shigella sonnei, which has been associated with sexual transmission among MSM for several years. So in addition to this increase in cases, these cases are highly drug resistant and are resistant to 7 classes of antimicrobials, specifically having a genotypic marker which confers resistance to ceftriaxone. So this can be seen on the right-hand side of this figure in red. So we're concerned about this because this may lead to increased severity due to reduced susceptibility to antimicrobials. We're also concerned for the potential of transmission outside of sexual networks, particularly if this involves settings including vulnerable populations. And also there's the potential that this AMR determinant could be transferred to other pathogens. So this situation was declared a national outbreak in December 2021, and the UKHSA established an outbreak control team. So in addition to monitoring the epidemiology of the outbreak, a range of activities were undertaken to raise awareness among both the public and healthcare professionals. So this involved updating various information resources and sending out alerts. So between September 2021 and the 2nd of April 2022, we've had 89 cases that are part of this outbreak in England. So this is within a context of about 600 cases of Shigella among MSM in that same time period. But it's also worth noting that we've had cases reported across the UK and also across Europe. So 98% of adult cases within England are among adult men. And as mentioned previously, this outbreak is characterized by really high antimicrobial resistance. So over 90% of cases have that marker for ceftriaxone resistance, in addition to being either multi or extensively drug resistant. So enhanced data for nearly half of confirmed cases confirms that the vast majority identified as MSM of white ethnic background. However, there is evidence of transmission outside sexual networks. So the suspected country of acquisition was most often reported in England, with contexts including sex with one-off partners and attending sex parties and public dark rooms. So the clinical severity of cases really stood out. So nearly half of cases attended A&E and required antibiotic treatment, and 23% were hospitalized. In contrast with findings from previous outbreaks, nearly 3/4 of cases were HIV negative MSM on PrEP. So this indicated to us that there is a need to integrate health promotion for shigellosis within the routine delivery of PrEP. So just some key messages to pull all of this together. So firstly, recent trends suggest that sexually transmitted shigellosis among MSM is increasing and returning to near pre-pandemic levels. There's also an ongoing outbreak of extensively drug-resistant Shigella sonnei among MSM, where cases have concerning clinical severity. So it's likely that more work is needed to raise awareness of Shigella as an STI and to signpost cases to sexual health services. Thank you very much for listening, and I'm happy to take any questions.
That's great. Thank you for that, Hannah. Yeah, if you've got questions, please raise your hand or pop anything in the chat. Hi Claire, I think I'll start with you. Thanks for coming today. I guess before you have a specific question yourself, if I could quickly ask you one. Obviously it's quite concerning, the antibiotic resistance levels that we're seeing here. How concerned are BASH, and what work are you doing in this area to combat this, and in other STIs as well?
Yeah, so we are really concerned about it, not just for the impact that AMR within Shigella has, but also, as you'll be aware, gonorrhea of resistance is on the increase, and we've had a handful of cases of, I think, of ceftriaxone resistant gonorrhea, which is the first line therapy, that, you know, there is some talk about chlamydia resistance, although we haven't clinically seen a great deal of that. So general antimicrobial resistance in STIs is increasing, and we are concerned about it. BASH, we have a specialist interest group called the Bacterial Specialist Interest Group, and they've been doing a huge amount of work over the last couple of years to gather evidence for, you know, things that we could do. So we are literally just about in the next couple of days to release a letter to the Chief Medical Officer and the Chief Pharmaceutical Officer about the use of antibiotics online, and we're mainly calling for more restrictions around acquiring antibiotics without a diagnostic test. And obviously we've been working with our colleagues at UKHSA to drive that, and that's really a multi-agency approach. So we're starting with looking at how we can address access to antibiotics without testing. We obviously need to look at ourselves as well. So in sexual health clinics, you know, for a very long time, we've issued doxycycline to people who might have a, you know, third person party referral that I've got chlamydia, so we'll give out some doxycycline, and that's obviously, although it doesn't affect Shigella resistance, it is implicated in problems with treating Mycoplasma genitalium, and that's another major concern around antimicrobial resistance. So we are really concerned. We're raising this both with partners in UKHSA and also sort of nationally around chief medical officers and restrictions, and trying to work with other people that deliver online pharmaceuticals. And yeah, so does that answer your question?
Yes, thanks. And did you have a question yourself?
Yeah, there's loads more to do. I wanted to ask Hannah and Katie, is there epidemiological evidence that Shigella resistance is driven by antibiotic use? So I was reading up about this last week about gonorrhea, and I mean, obviously it's plausible, it makes sense, but is there data that suggests that?
There's I guess it's more circumstantial than anything proven. There's some nice work that has been done by Holly Mitchell, who works with us, which is she's just been submitted for publication, which is looking at the association of markers for antibiotic resistance and treatment for previous bacterial infections. So it's emerging. It's not really cut and dried and fully understood yet, but I think that's the suspicion lurking, that there's this exposure to antibiotics is causing increased antibiotic resistance in a number of different infections. Watch this space, because there's quite a lot of work going on it, but there's a lot of things we don't understand about how this spreads, why it's becoming so resistant, how it interacts with other infections and their treatment.
Yeah, that's interesting. Okay, thanks, Katie.
I can see there are a number of questions in the chat.
Katie and Hannah, if you want to take those, which ones you feel you can.
I'll start, and Hannah, feel free to chip in. There's a question, is there resistance with azithromycin? Each of those, there's a number of different strains in circulation. So there are a number of different strains of Shigella flexneri circulating, as well as several types of Shigella sonnei. We see the majority falling within 4 different clusters circulating. They've each got a different pattern of antimicrobial resistance. So some are resistant to some types of antibiotics, some are resistant to others, or a combination of them. They're all multi-drug resistant. Some are resistant to azithromycin, some aren't. So it's really important that your infection is tested for antimicrobial resistance to make sure you get the right treatment. So there's not a straightforward answer to that question, but they are variably multi-drug resistant, and these Shigella sonnei cases we've seen lately are extensively drug resistant to 7 classes. There's a question about incubation. Is it the same when acquired via sexual contact rather than the GI route? Well, the infection is always acquired via the GI route. It's always from ingesting bacteria, and it only needs to be in very small numbers of bacteria to cause an infection. It doesn't even need to be particularly visible. So whether it's acquired through sexual contact, it's through ingesting bacteria, through contact with feces, may not be visible at all. It could be off surfaces, it could be off infected materials or towels or other things in the environment. So it's always via the GI route. The incubation is the same. It might be shorter or longer depending on the infectious dose, but it's a short incubation period. What type of sex has the highest risk for Shigella? So any types of sex that might lead to contact with fecal matter. Often it's been associated with use of sex toys or sex in group environments. So I guess, but it's also what we've seen from talking to people in the latest outbreak. It can be just an unexpected, there's nothing particularly different about the type of sex people are having. But generally speaking, the work and the research and the surveys that have been done to have a look at this find that it can be in group sex environments. I guess that just increases your exposure to the numbers of people, some of whom may be currently infected.
Thanks, Katie.
Thanks.
Sorry, I was stuck on mute. Do you want me to cover the next one?
Yes, please do.
Cool. So a question from Maria about what's the best advice for protecting oneself. So I think it's mostly about practicing good hygiene after sex. So that's really important. So, and also avoiding oral sex immediately after anal sex. And if changing of condoms and just washing your hands with soap and water, that's going to reduce your risk. Dental dams has been suggested. Yep, I think that would also reduce your risk as well. Yes, I think, Katie, would you like to add anything?
No, all the materials that are being recirculated by HIV Prevention England include the good range of advice. So that's on the leaflet and in brief on the posters as well. And it also links to other sources of advice on, again, in good hygiene, hand washing, other ways to both prevent infection, but also to look after yourself if you find that you have got symptoms. So there's a link to the website on making sure that you keep hydrated when to go and seek medical help if your symptoms aren't getting any better as well.
Thanks. I think you may have just dropped off screen, but if Greg, I think you had your hand up for a little while. If you've got a question, thanks.
Sorry, I dropped out and had to come back in, so apologies if I'm asking a question twice. Just quickly, the 2015 reduction in cases, was there an explanation for that? Because it's almost the same as recent lockdown. What was the explanation? That's the first question.
Yeah, so we really started recognizing increases in Shigella a couple of decades ago now, and it used to come as waves. So you would see an increase and then a decline again, and then another increase and then a decline again. What we've seen more recently is that we don't see a reduction back down to those very low levels in between these periods where there is an increase. It's not totally clear what's behind that. It might be that we've just got a number of kind of waves that are superimposed on each other, so we never actually return back down to a time when there's very little infection in circulation. Or it might just be that we've seen overall a general increase, and we'll never return back down to those very low levels in between the waves. We'll just return to a lower level. So what we've seen, we saw in 2019 almost a record high level of reports, and we know that we're only seeing probably the minority of reports, people who are clinically unwell, who do go to see their GP, who do get a sample taken, which is diagnosed and reported. So no, there will be more of these infections circulating. We know that we've been seeing an increase, just a gradual increase over the years, and we haven't seen since 2019 a return back down to those very low levels. So it seems to be something that is increasingly prevalent, that we will continue to see. We'll continue to keep having to re-emphasize the messages on how people can recognize an infection and what to do about it.
Thanks, Katie. Claire, sorry, Greg. Claire, did you have something to respond to that too?
Last question was on the 73% on that were PrEP users, HIV negative on PrEP. I presume that's to do with an increased regularity of monitoring.
So that information was obtained through interviews. We used a questionnaire to obtain that information. So it wasn't through routine reporting of PrEP use. So the way in which we didn't do, it's a pretty representative sample, the ones that we did interview, but it was sort of, there's a bias in terms of who responded to our requests for interview, but no, not based on routine reporting of use.
Yeah, I was just going to say as well on that last question about the sort of the never returning to the bottom level that Katie mentioned, is there has been some really interesting stuff, and I'm fairly sure that Katie was involved in it, looking at whole genome sequencing to track what happens. And we think from looking at that sort of early work that there is a lot more sexual mixing than there perhaps used to be. So people who identify not as MSM but are having MSM sex with other men are mixing more across those groups. And I do think so often you look at these patterns and they're driven by sexual behaviour change, and that perhaps this is early picking it up. And it'd be interesting to see if more of this interest in whole genome sequencing, where they look at the specific type of bug and they map where it's been. That would be really interesting to see more of.
Yeah, definitely. And we've certainly seen evidence in this current outbreak of what looks like spillover into outside of sexual networks.
Thanks. We've got another question in the chat for our colleagues at UKHSA just around the communications. Obviously, I know your initial ones were sent out at the end of January, I believe. Has anything further been sent out?
Not that I don't think so, Katie.
Could you repeat the question?
Yeah, sorry, Katie, it's the one in the chat from Robbie Curry. What comes into who has been sent out by UKHSA, and what actions will integrated sexual health services need to take?
Okay, so the main information that's been sent out is in the form of the briefing notes that go out to microbiology, to clinical colleagues, to local authorities, just raising awareness that there is this increase, and in particular what to do in terms of treatment options if there is the extensively drug-resistant Shigella sonnei diagnosed. So that's the main professional communication that has gone out. There's also been a couple of international bulletins that have gone out, both via the European Centre for Disease Control and the WHO, because certainly the extensively drug-resistant cluster is an international outbreak and is of international concern. So those are the main things that have gone out. There'll also be a publication, and we will update in terms of the general Shigella picture. So beyond the extensively drug-resistant cluster into the general elevated picture, we'll be updating our epidemiology report. That's mostly statistical.
I can see there's just a follow-up to that around communications that have gone to GPs. I know certainly HIV Prevention England have been using our primary care contacts to disseminate information. Has anything specifically been sent from UKHSA to primary care colleagues?
Yes, we sent out a cascade through the GP newsletter, and I forget what it's called, but we put a very short article into that, linking both to the press release and other information that was available. So it was a kind of cascade through that newsletter route at the time that we recognised the resistant cluster.
Thanks. We've got another question from James Wilson. It's regarding treatment and following testing. I don't know who's best to pick that one up, whether it's Katie or Claire.
I'm happy to, although I'll probably pick Katie's brains at some point. Yeah, so so most people, I think it was only about, wasn't it, 30% of people, seems like a lot still, that actually needed hospitalising, but 50% of people thought it was bad enough to go to hospital and A&E. So in an ideal world, if it's clinically mild, you wouldn't receive antibiotics and you would have supportive therapy. So stay at home, drink lots of fluid, take paracetamol if needed. But at least a third, it seems, are requiring treatment, and those people will need antibiotics. So I guess we have to kind of, each person has to present as required by, need. So my worry about this is that there'll be a lot of people who would access online antibiotics when in fact, they might feel unwell, but clinically they didn't necessarily need antibiotics. Because that will obviously drive resistance, but it's also very hard to advise people not to get any antibiotics online if they're feeling unwell. So it is really tricky. Empirical treatment isn't a good idea. We do it for lots of things, but we I think that is partly why this is coming home to roost in terms of AMR now. So we probably all need to look at our prescribing behaviours.
And I think that the specific guidance for this is being updated shortly, so that will be a BASH guidance coming out in the near future, I hope. There's a question about whether cases had been diagnosed in Scotland. Yes, we have seen cases in all 4 UK nations, as well as in other countries in Europe, but yes, it's certainly throughout the cases of the extremely drug resistant cluster. Those are the only ones that we've done the pan UK surveillance for.
And I think you've touched on sort of like guidance coming out. There's a question in here also around the questionnaires that are used by health protection teams and whether there's any program to update those. Yeah,
so that's a work stream that's in development. What we want to do is include more questions that capture better sexually transmitted information. So we want to include or update the questionnaire with findings from this recent outbreak. We don't have a timeline for that work yet, but we're hoping in the next few months to progress that.
Thanks, Hannah. And sorry, if you could just repeat, Katie, any recommendations for the integrated sexual health services, or if Claire, you've got any comments on that as well?
Yeah, so it'll come down to the BASH guidance, which is being written as we speak with colleagues from across the sector. I think one of the other things that we're advising people to do, we had a little webinar, which I think, Alex, you might have been at. We had one of our BASH Q&As that happens on a Wednesday evening. We've sent some of those informatics that you've developed out to clinic users and also to clinic leads, and what we're asking them to do is go around their hospitals or local health environments and teach and train about this, to raise awareness that it's not just picking up the Shigella that's the issue, it's then saying to them you probably need an STI screen. So I think if you present with diarrhea in an STI clinic, you're going to get an STI screen, you're going to get everything else done, you're going to be checked for HIV. But if somebody presents to an A&E department and just gets told, oh, actually, you've got diarrhea, you probably don't need any antibiotics, they won't necessarily give them that information. So we're asking all local services to raise awareness within the local health community. We've already started doing that and done a grand round amongst the medics and the medics and the nurses in our trust, and we've got a plan of other things to do locally. So I think that's another part of the job, really, is to raise awareness.
Thanks. There's a question here around could the increase be due to laboratory pickup as more labs move to molecular techniques?
It might be. There might be. It might be increasing our ascertainment, but Shigella is not the only infection that we're seeing increasing. We've seen, and in particular, the uptick after COVID restrictions. So we have seen a recurrence of LGB as well. Syphilis in particular is at high levels again, almost to pre-pandemic levels, and both of those were also at a historic high level in 2019. Before the COVID restrictions kind of caused a brief dent in their numbers. So it's not the only infection that we're seeing. It's just unusually high and unusually virulent. And the figures that Hannah showed of people who were attending A&E and being hospitalized, they're not untypical of other types of Shigella as well. So as we're seeing those increased numbers of Shigella overall, we're seeing increased numbers of people who are having a severe reaction or severe experience as a result of their infection. So it's not the only one that is increasing. We're seeing increases in a number of other infections as well.
Yeah, Claire, did you have something to add?
Yeah, I mean, I just wanted to sort of slightly address the elephant in the room that it is, I mean, I am worried about access to services, not just sexual health services, but all health services. And I do wonder how much of that is driving it up. I think it's probably a combination of access to services appears limited, whether that be sexual health services or primary care. But in addition, probably people's behaviour has changed post-COVID. You know, I do worry about lots of people's mental health that I see. You know, none of us are living in a bubble. So when we see people in clinics and they're fed up and they've got no money, of course that impacts on your sexual behaviour, doesn't it? And, you know, like it's just human nature. So I am worried that access is restricting the ability for us to keep a lid on these things in a way that we possibly could 5 or 6 years ago from a clinical point of view. Obviously, UKHSA are doing an amazing job, but we probably aren't able to see all the people we need to see.
Thanks, Claire. And there's a question which I know Bash is looking into this area around online antibiotic uptake and purchase, and whether that's linked to lay referrals and social sexual networks, and if there's anything that we can do about that. You're on mute, sorry.
I was muted, sorry. I forgot to, I muted myself and forgot to put my hand down. Yeah, I am worried about online purchase. There's an awful lot of stuff, talk around antibiotic prep as well. And, you know, I can completely understand if you're a patient, how frustrating it is not to be able to get in, and therefore why wouldn't you just buy an antibiotic online? I get that, but there is more work to do. THT and Bash have committed to it together to you know, and with other people across the Sexual Health charity, and have a look at this over the next 12 months. We are raising awareness nationally. We're trying to do some local raising awareness in all of our services. So yeah, I think there is still quite a bit of work to be done. I think I do worry about online purchasing before getting a test. One of the things that we need to make sure is that people can get the test when they need them. And that doesn't relate to Shigella quite so much as other STIs, but that is still an issue for people. And obviously a PrEP changes we were just talking about this today in clinic, PrEP changes the dynamic a little bit. So we see things behaving differently, and perhaps maybe we haven't, as services, quite got on top of that yet.
Thanks. A question here for UKHSA colleagues. If we've seen similar clusters of enteric bacteria, so Salmonella, Campylobacter in MSM groups at all, is it just Shigella?
There have been occasions in the past where other infections have been seen in clusters, Giardia, for example, not at the moment. And certainly overall, Shigella is the one that we see mainly in this context. The research that I've mentioned before, done by Holly Mitchell, did some work at Dean Street, just looking at what the prevalence was of enteric bacteria just generally in people attending a sexual health clinic. That's about to be published. It did find a number of different infections, but they're not causing the same type of outbreak as the one that we're seeing with Shigella.
Thanks. And Hannah, there's a question here around inequality trends, and is the team, are you doing any work around this? Is there anything to look at within that space?
So in terms of inequality, say based on index of multiple deprivation, the data source unfortunately that we use doesn't capture that information explicitly, so we wouldn't be able to look at inequalities from sort of a social demographic or social deprivation aspect. But you know, we can look at we know that it's mostly MSM, so you know there's an inequality in that perspective. But yeah, we're sort of limited by the variables that are collected in the surveillance data set that we use.
Thanks,
Can
Hannah.
I just add to, yeah, can I just add to
Sure,
that? That's completely right what Hannah's just said there, but I also wanted to add that I tend to assume at the moment that you know, access is restricted, generally speaking. Those with the lower socioeconomic status tend to be restricted more than those with a higher status, and that's just a general assumption. So I think there is lots of work to be done around leveling the playing field a little bit, which is it's really tough to do at the moment because resources are limited in all settings, aren't they?
Thanks. There's a question from Richard around, would making dental dams more available help reduce the figures? I'll let yourselves answer this, I guess, from the point of view of the information that we're sharing with people through the kind of relaunch of the campaign at the moment. We're very much enabling people to access information about how they can protect themselves with things like that. But we also know that lots of people aren't using them, you know, particularly if they're going to be like in a dark room in a sauna. It's unlikely, which is why we're also including all the information about making sure that people are, you know, washing their hands, washing their body and that kind of thing as well. I don't know if there's anything else you want to add at all with that.
No, thank you.
Okay. And Harvey submitted a question around the training. I'm not sure if that's sort of just in general or if specifically what Claire was talking about with regards to resources or placing to support organisations to accurately and constructively train their workforces, or is it up for them to pull it together? And is there anything that's CPD ready?
Oh God, you've hit on my bugbear, Harvey. No, I can't make anyone take interest in this. I can go around banging on about it as much as I like, but I can't. There's no requirement for trusts to train people in this, which I think given around it's around AMR, which is a major worldwide health issue, is a shame. But no, I can't make anyone train on it. There is some. I don't know if you guys have come across e-learning for health. And I know that enteric STIs is on there, and I think that's just recently been developed. So if you wanted more training, or if you wanted to direct people to more training, it is on there. In terms of CPD ready, I mean, yeah, the e-learning for health is CPD ready. What we've done locally is we've just gone around teaching and training people about it, so that hasn't required CPD. But it's possible that the Bash conference will have something on this. I wouldn't be surprised if the Beaver conference has something on it either, which of course will come with CPD. But if there's a particular need for some specific training with CPD attached, we'd be really happy to hear from you if you wanted us to organise something. Yeah. So and then the next bit is figures of elevated prevalence in white MSM. Is there any preventative work being done to target demographics of people who aren't yet present to services with Shigella? Well, I mean, other than the work that we've already talked about, I'm not sure. So we've liaised with our commissioner, who obviously is a public health, got a foot in the public health sector, and there locally we are discussing this with, in particular, the support services around drug use services and also around sex worker services. And they're going to be doing a little bit around sort of asylum seeker services as well. But I don't think there is a national programme yet to look at how we address this amongst other groups of demographics.
Thanks, Claire. I think okay, yeah, we're just a comment.
That's really annoying.
Of
That's really annoying. Oh, Liz, I don't know how. I don't know. I'm sure there's a way to navigate this, Liz, but I'll need to think about it because we do have some really good stuff on there. We actually have a BASH one of our BASH board members actually develops all the sexual health stuff. So I'll take that away and go and think about it.
Okay, maybe that's something that we can investigate for everyone. Are there any other final questions? If not, I'd just like to thank Claire and Bash and Hannah and Katie from UKHSA. My colleague Cham's just dropped a survey link in the chat. If you can just click that, it's just a quick evaluation survey. It just takes a couple of minutes. And just to remind you all again, you can access the resources both for health professionals and for your local communities via our website at hivpreventionengland.org.uk. Thanks.